I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the March 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, PRS Resident Ambassador from Northwestern, and I'm joined by my co-ambassadors Jordan Frey from NYU and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Nolan Karp, Professor of Plastic Surgery at NYU. Thank you very much, Dr. Karp, for joining us for the PRS Journal Club podcast.
You're very welcome. I really appreciate the opportunity.
So the article that we'll be discussing first is Facial Contouring by Targeted Restoration of Facial Fat Compartment Volume, the Midface, by Drs. Wang, Shi, Huang, Zhu, Herler, Zhao, Cheng, Zhu, Pu, and Li from Shanghai, China, Sacramento, California, and Munich, Germany. As a quick reminder, all the articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So I think we all know that multiple techniques exist for fat grafting to the cheek, and there's really no universal protocol. And we also know from Dr. Rourke and Pessa's landmark paper that fat is contained within several compartments in the cheek in both deep and superficial layers. So the author's goal was to describe their fat grafting technique that resembles the fat distribution in a youthful face. So there were two parts of the study. The first was a cadaver study. They dissected 40 cadaver hemifaces, and they specifically dissected the fat compartments, along with their bordering fascia and ligaments, as well as the angular artery and vein. And then they also performed a human study where they presented their technique in 78 women who were undergoing fat grafting from 2010 to 2014. So in their technique, what they're doing is they're harvesting fat from the abdomen or thigh. They're first making a oral mucosal commissure incision, and then they inject the fat compartments first of the deep cheek compartments. So they start with the medial deep medial cheek compartment, and then the lateral deep medial cheek compartment, then the medial suborbicularis oculi fat, and then the superior buccal fat pad. And then finally, they move on to the superficial fat compartments, starting with the superior medial cheek compartment, the superior nasolabial fat compartment, and then the superior nasolabial fat compartment below the tear trough, and then below the nasolabial fold if needed. Then, through a preauricular incision, they'll approach the middle and lateral fat compartments in order to get around the mesenteric retaining ligaments. So how they assessed these patients after they underwent this fat grafting protocol was they looked at malar lipoatrophy grade pre-op and at 12 months, and they also performed a satisfaction survey at 1 year. They also performed 2D images as well as laser surface scanning of patients with comparisons from preoperative and 1 year postoperatively. What their results showed was that, starting with their anatomic study, they noted that the deep medial cheek compartment was actually divided into two parts. They noted it was divided into a medial and lateral part by fascia that came from the levator anguli oris. And then they also noted that the medial portion was above the canine and first premolar, and the lateral portion of that compartment was between the first premolar and first molar, just to give us some operative guidelines as to where to aim the cannula to inject these compartments. They also noted that the angular vein was within a superficial septum between the lateral deep medial cheek compartment and the buccal fat pad, essentially 12 millimeters away from the maxilla. Now, in their clinical study, what they saw was they performed fat grafting on 78 patients with an age range of 18 to 53 with a mean of 35, and they injected between 4 and 25 cc's of fat per cheek. This was spread out over 2 to 3 procedures. Each of these were spaced out over a mean of about 4 months apart, and the total volume for bilateral cheeks was a mean of 29.3 cc's of fat injection. So they noted in their results that patients subjectively had improved contour. 76% of patients were satisfied, 18% were mostly satisfied, and then 4.8% of patients were not satisfied. They also noted that malar lipoatrophy decreased from 3.3 down to 1.0. And then whenever they used their laser surface scanning, they noted that the cheek augmentation rate was approximately an increase of 27.1% of volume. So overall, these authors are recommending a deep to superficial and a compartment-based injection strategy. They also noted that if you inject the deep compartments, this provides protection of the zygomaticus and also resolution of the tear trough and helps to efface the nasolabial groove. They also noted initially it was difficult to approach the middle and lateral cheek compartments without making a second stab incision in the preauricular area. They think probably because the mesenteric ligaments basically resisted their cannula from passing between their commissure incision into those middle and lateral cheek compartments. So overall, I thought the authors presented a very methodical and anatomic technique for injection of fat to the face with some good results, but it's hard to take away much, at least technique and results-wise, given that they had a wide disparity of ages and volumes used. So, Dr. Karp, I wanted to know what you thought about this article, and also, they're very methodical about injecting each compartment separately, and I wanted to know how important you thought it was to anatomically inject each fat compartment whenever you're performing fat grafting to the face.
I thought it was a good article. I thought they had nice results, and I thought they were very meticulous about how they did it, and I think that made it, very believable, and I thought the results overall were quite good. I think that at the end of the day, what you really want to do when you're doing fat injection to the face is you want to make the face look better, whatever you're trying to correct. We in this country are not doing this age group of patients for the most part. We're usually doing older patients in combination, with other surgery like facelifts for improving facial appearance in probably a slightly older group of patients. So I think it's important to know about the compartments. It's important to know that, if you're injecting one compartment, it's not going to go into another compartment. We used to think before Rourke and Pessa's article that the face was really just one entity, and their article is very important, but I don't know that you absolutely have to stick to injecting each compartment in that deliberate way, because at the end of the day, what you really want to do is affect the overall look.
And what do you think about injecting deep versus superficial compartments?
I think that's important. I think a lot of the aging happens actually in the deep compartments. So I think it's important to actually inject that. I think their method is very good, which is start out deep and sort of going from medial to lateral and then do superficial. So I think it is important to do that. I think deflation of the deep compartments is, a big component of facial aging.
Great. Thanks a lot. Shuja, what did you think of this article?
Yeah, I have to agree. I mean, I thought it was a very good paper. I thought it was very detailed, very methodical. They obviously had a good number of patients over a long period of time. And I think the anatomic cadaver dissections add a lot of knowledge that we've already had, but elaborated upon that in terms of augmentation for facial rejuvenation. One thing I wanted to kind of elaborate on and ask Dr. Karp is that you mentioned the age range in this paper. So their age range was really wide, from 18 to 53 years old, with the average age being around 35, which, again, as you mentioned, for us in the U.S., that's a pretty young age for patients to undergo any sort of facial rejuvenation. So do you feel that isolated facial fat grafting is something that should be or could be performed on younger patients to potentially avoid having a facelift or maybe stave off having a facelift in the future? Or do you feel that it's more useful the way we do it as an adjunct to a facelift or surgical facial rejuvenation?
I think there's differences in different parts of the world. I think what you're really seeing in Asia is the desire to change the appearance of the face. So you either have people wanting to make their face rounder, where they're more angular, people want to change the projection of their face, or and sometimes people making a rounder, wider face narrower. And I think this is just a different thing. I mean, it's not really about facial aging, it's about facial appearance. And I think that patients get to a certain age and they realize they don't like their appearance, and then they want to change it. So it's not something we do in this country, but I think that this article really opened up my mind to thinking about this and realizing that if somebody came in, I think, I would certainly consider fat grafting as an option, particularly, if they have decreased mid-face projection, or if there's certain areas that they want to change. I think fat is really a great way to do it.
Is there any specific technique that you use to prepare your fat after harvest before you inject it for grafting?
I haven't done this age group, so most of the time I'm doing a facelift patient. So what I do is different than what I do for, let's say, breast fat, where I need a lot more fat, and I suction, big area and put it in the revolve machine and wash it. I don't do any of that for this. So what I would do is do typically syringe liposuction, abdomen, outer thighs, at the very beginning of the case. And I get a couple of syringes of fat, and then I just let it sit. I don't centrifuge, I don't do anything. I just let it sit. And then I would go on and do the facelift, and usually inject this towards the end of the procedure. Some people inject in the beginning, so they may want to do something with the fat, either centrifuge it or something like that, but I usually do it at the end of the procedure and then inject it very similar to how they describe the injection. But usually I have specific areas. My volume is probably a little less. I mean, they're doing 4 to 25 per cheek, and an average of 29 total. So you're probably looking at 12 to 15 cc's per cheek. Probably in a facelift patient, I'm doing somewhere like 5 to 10 cc's total. And I'll mark it all out in the beginning and do it towards the end of the case.
Jordan, what did you think about this paper?
So I agree with everyone's analysis so far. I think this is an interesting paper, and I think it's interesting that they isolated fat injection to the face to really examine the effects, especially in a more young population. I think it's always important to look at in these studies how outcomes are evaluated and results are analyzed. So, Dr. Karp, what do you think is the most objective way or the best way to evaluate outcomes in facial aesthetics in studies such as this? In this study, they used 2D images and laser surface scanning to evaluate their preoperative and 1-year postoperative results. What do you like to use in your office? Are you using 3D imaging? I'd be interested to hear what you think about that.
I think that 3D imaging is a great way to assess this. One of the nice things about 3D imaging is you can do an overlay, an addition or subtraction. You can compare two images. A computer will align them based on the anatomical landmarks, and then you could see the difference. And they did this actually in the paper. They showed that the areas where the increased fat uptake, it showed very obvious. So I think it's a really good way to do it. I think that as we get more sophisticated, I think 2D pictures are very nice, but if you don't standardize the lighting and the makeup and all these things, it can be very deceiving. You can make somebody who you've done nothing on, but change the lighting, change the makeup, change everything, and it looks like they had a great result from surgery when they never had surgery. But 3D imaging really doesn't lie. So I think it's excellent for this. We use this. I use it both for pre-op and post-op management, but particularly in pre-op. I haven't done it for this specifically, but I have done it for patients I have fat graft to other areas, or I subtract fat, and you can just very easily with the 3D imaging add or subtract fat and show patients what they're going to look like, and you can also quantify the difference, and you can figure out how many cc's different they retain. So, you may have injected 10 cc's on each side, and the 3D scan may tell you, there's 12 cc's total difference, so you retain, 60% of your fat.
Dr. Karp, this is Chad again. I guess I have one more question for you before we move on to another article. These articles were using 2 injection sites per side. They were using a commissure incision and then also a preauricular. What are your typical incisions, and what areas of the face do you access through each of them?
I think the commissure incisions are great. Incisions in the mouth, you can't see it. Again, I'm usually doing this at the time of a facelift. So I will sort of use the incisions I have or go through the incisions I have to inject the fat, sometimes just prior to closure. So if I have a facelift incision, I may go through that incision, so I'm not making an extra incision. I think if you're injecting around the nose immediately, I think the commissure incision is a great incision. So I think their incision choices are excellent and provide access to most of the areas of the face for injection.
Well, with that, I think we'll end our discussion on this article. Remember to tune into the other 2 articles that will be discussed in this month's podcast, as well as the PRS Journal Club podcasts that will be broadcast every month. Also, don't forget to participate in our monthly Twitter PRS Journal Club, where we will be able to interact directly with this month's selected articles' authors. Thanks again, Dr. Karp, for joining us.
You are very, very welcome.
Join the PRS Journal Club. Read the monthly picks and classic pairings on PRSjournal.com. Discuss with the authors on Twitter at PRSjournal and listen to the podcast